they just told me I had fibromyalgia and to go away, because we can't treat it, particularly with anything.
Fibromyalgia syndrome, they have to be minimum of 65 years old or above.
Absolutely not. You're going to get sued and you'll lose. But the patient, they go blind. We don't have pictures. We don't know what it looks like. If you don't specifically know what you're looking for, don't do it.
How do we tell the patient time and time again, RF factor is one of the investigation, that is not the golden. Jack, thank you for joining me on another podcast. I want to talk about more details of immunological conditions and also connective tissue disorder. And being a physiotherapist, and connective tissue disorder diagnosing and detecting is quite hard or not well educated. And you lived and worked in that area of rheumatology for a long time. Share your experience about, this is mainly for physiotherapists who want to learn, develop their skills in rheumatology and connective tissue disorders. How hard it is to diagnose a connective tissue disorder?
Yeah, it's really hard. So we have multiple problems. I when I teach courses, I teach a full day course, and there's a joke I make at the beginning. It's not really a joke, but it's sort of funny, really, in that rheumatological disorders masquerade as musculoskeletal disorders, and then you've got connective tissue disorders that masquerade as rheumatological disorders that masquerade as musculoskeletal disorders. So you've got lupus, for example. Any symptom you can think of, pretty much, could be caused by lupus. It's so wide-ranging, and as you said, it's because they're a connective tissue disorder. So connective tissue is throughout your entire body. There is pretty much no organ without any connective tissue in it. So if you have an immunological cause for problems in connective tissue, it can go all over the place. Skin, joints, bones, eyes, saliva glands, stomach, etc., everywhere. And so the reason it's really difficult is that the symptoms presenting can be very, very vague, but they also typically will present in populations who also present with relatively vague symptoms. So again, you look at something like lupus, the most common symptoms for lupus would be things like fatigue, general joint pain, general joint aching, and that's going to present in most predominantly females about 30 to 50. And of course, they have a whole range of other issues that can cause exactly the same symptoms, which are very common. So you will typically see those symptoms put down to things like perimenopause, or other hormone imbalances, or other disorders like fibromyalgia or chronic fatigue syndrome, etc. Because it's very difficult to find specific findings. If you think about something like psoriatic arthritis, someone's got psoriasis, it's quite an obvious smoking gun most of the time, whereas with these diseases that doesn't exist, and so it's very difficult. And then you extend onwards, the investigations can be difficult to do. You can't always get them outside of a specific rheumatology department, and so the whole process is very challenging.
And where would you classify this people with the fibromyalgia, polymyalgia, rheumatica? Do they come under connective tissue disorder or autoimmune disorder in general?
So polymyalgia rheumatica is the easier one to answer. That seems now, in sort of more contemporary versions, to be more related to a vasculitis, so inflammation of blood vessels.
Yes.
Although it's still proving very difficult to quite understand exactly what's going on in polymyalgia rheumatica, but tends to be more like along the vascular line. Whereas fibromyalgia, there's various theories as to what's going on there. It could be neuroinflammatory, so inflammation within the nerves, the peripheral nerves, but that's still under sort of scientific scrutiny, really. So it's very difficult. I wouldn't like to put my hat onto a specific cause for fibromyalgia currently, but I think it might be autoimmune, but again, I wouldn't be definitive on that. But certainly, potentially something to do with inflammation around the nerves would be probably the most promising direction that research is going.
Many years ago, we were told that if you want to diagnose a patient with fibromyalgia syndrome, they have to be minimum of 65 years old or above.
Oh, right.
Is that correct or not?
Absolutely not. So the 2016, I think they revised the criteria, and
Yes.
they're really quite good now, specifically. Because the other thing is, before that, fibromyalgia was a diagnosis of exclusion.
Exactly.
And how do you exclude everything is one thing. And again, another thing that I often say is, you've got to know you're specifically excluding others. You can't have a diagnosis of exclusion if you don't exclude stuff. So it's quite difficult, but it is quite specific. There's a form that scoring system, so people have to have pain in a certain number of areas of the body. They have to have cognitive symptoms, fatigue, sleeplessness, depression, those kind of things, and also a symptom severity of a certain level. So you combine those scores together to make a diagnosis of fibromyalgia syndrome. And you also, it's not sort of in isolation anymore, so you can have it either independent of other diseases or coexisting with other diseases. So a lot of people with chronic health problems satisfy the criteria for fibromyalgia syndrome. So you could diagnose them with that. Whether you would is another question. But yeah, another very complicated set of systems we've put in place, and some of those are better but not perfect. And I hope we would see more research into being specific with those people, because a lot of times, especially with fibromyalgia, people can feel like, oh, they just told me I had fibromyalgia and to go away, because we can't treat it, particularly with anything. So it feels like you're being fobbed off and sent out because you're a bit difficult as an individual, or whatever the issue is. But it's better.
Yes.
It's not perfect, would be my suggestion.
And a couple of other things related to the same thing. Benign hypermobility disorder.
Yeah.
Do we straight away exclude or try to confirm whether the person has got a fibromyalgia syndrome or not?
Oh, with people with hypermobility.
Hypermobility
Goodness,
disorder.
yeah, so difficult. So the problem with hypermobility is you've got different sections of hypermobility. So I'm hypermobile, but it doesn't cause me any problem. Especially now I'm old enough, I don't bother with sport so much anymore. But it doesn't cause me any issue. And about 25% of the population are hypermobile by whatever definition you might. But not all of those obviously have a problem. But within that 25%, some of them are going to have arthritis, some of them are going to have diabetes, some of them are going to have whatever else, because it's a large section of the population. So the challenging part, as you say, is what symptoms are being caused by the fact that joints are hypermobile, what is being caused by other things, and trying to separate that out. I would typically try to work out what are the symptoms that are caused by the hypermobility. So did they predate whatever the complaint is now? Was there initiating injury related to instability, and that kind of thing, and then go from there. I think you have to judge it on an individual basis, and I try to go to people, is diagnosing fibromyalgia in this situation going to be helpful or not? Or is it just giving them another label they've got to deal with, and try to make that decision? I wouldn't like to say get it right every time, but that's the kind of decision you've got to make. Because like I say, it's not like you can go, oh, you've got fibromyalgia, here is X pill, now you'll feel better. It's still very much about lifestyle management and help and assistance with general health and exercise, etc. So it can just be going, oh, now I've got another diagnosis. But for some people, it could be really helpful. So you have to try and make that distinction.
Exactly. And if a patient comes with a temporal arteriitis,
Yes.
do you straight away suspect patient might have a polymyalgia rheumatica? What is the connection here?
Okay. So the giant cell arteritis and polymyalgia rheumatica, they exist on a spectrum. So technically, you could consider them the same disease. I hesitate to use the word mild about polymyalgia rheumatica, but I mean that in the aspect of it not being dangerous immediately. Whereas giant cell arteritis would exist at the other side, that is dangerous.
Medical
It's
emergency.
a medical emergency.
Exactly.
So polymyalgia rheumatica we can keep within the primary care system, so within the GP, typically treated with steroids. It's not going to cause you a medical problem. Hurts a lot, causes you a lot of stiffness, probably makes you feel rubbish, but it's not going to kill you or make you blind very quick. Whereas giant cell arteritis or temporal arteritis will make you blind very, very, very fast, and that is irreversible. So what we typically will say is anybody with polymyalgic symptoms, so bilateral shoulder pain and stiffness, and a temporal headache or visual disturbances, pain in the scalp, they go to A&E
Straight away.
giant cell arteritis until proven otherwise, because if you sit on those patients and wait and they go blind, you've got a big problem. Individually, as a clinician, you're going to get sued and you'll lose. But obviously, for the patient, far worse than that. They've lost their vision, etc. So you would be sending those patients to A&E and considering them giant cell arteritis until proven otherwise.
How do they treat it? Is it a load of steroids will be the best treatment option?
Yeah.
Because I've seen patients and they were treated them with quite a lot of steroid until the inflammation comes down on the temporal arteries, and patients have preserved their eye vision.
Yeah.
And luckily, nobody lost their vision. That is the first priority for me on those days. Now, let me come back to SLE, systemic lupus erythematosus. How common it is? What are the symptoms people get to see?
Yeah, so it's a relatively rarer disease. So we talked about in the previous podcast, rheumatoid arthritis is about 1% of the population. SLE is going to affect about 0.2%. So it's about...
That's low.
Yeah, so it is lower, but still not an insignificant amount of people. So 2 out of every 1,000 are still going to get it. So a little bit less common, but the main symptoms are going to be fatigue, muscle pain, joint pain, sort of generalised. But with systemic lupus erythematosus, the important part is the erythematosis, so the skin is affected. So they get these characteristic rashes.
Yes.
So typically across the bridge of the nose. I'm talking Caucasians. We'll come back to non-Caucasians in a second because it becomes a bit more difficult. But you see a characteristic rash across the face called a butterfly rash. Or a shawl rash across the top of the chest. So most women, it's predominantly women, they will go, I go out in the sun and I get sunburnt really easily. And it isn't. It's a photoreactive rash. So I literally was speaking to a lady 2 weeks ago, and she had this exact thing for years. Every time she went on holiday, I go on holiday, I get sunburnt really easily. It lasts for a month. And it's like, well, no, that's not what sunburn does. This is a photoreactive rash. And then you add joint pain and some other symptoms, and then it's more like lupus. It's much more difficult in non-Caucasian people because the rash doesn't show up so readily, or it shows up, and we go into medical issues all we like. We don't have pictures, particularly in non-Caucasian skin, in our textbooks of these rashes. They're more difficult to see. We don't have photos of it. We don't know what it looks like. So we talked about, again, in the first podcast, African Caribbean people are about 3 times more likely than Caucasian people to get SLE or Sjogren's syndrome, and yet we don't know what the rashes look like. So there is a lot of work going on to try and improve that, but it's more difficult to recognise, and so they then have to wait longer for diagnosis, and you get all these associated problems. So because of that characteristic nature, it does make it difficult. And then the other symptoms are so vague. But those are the main things you're going to get. You do get some other slightly more different symptoms. You can get kidney dysfunction with SLE. You can also get a condition called antiphospholipid syndrome, which causes multiple miscarriages. So I typically will talk on my courses about asking about that history, especially in the female patients. 1 miscarriage is probably not suspicious to me, but if someone's coming with multiple joint pains or fatigue, and they're 20, 30, and they've had 2 or more miscarriages, then I start to become suspicious of lupus. So it's really about trying to delve into that history and knowing what you're looking for, and that's where I think you're alluding to is how we don't get that in our training.
Yes, that's true.
There's no way we get that. And so it's knowing those associations, which we don't always know. We're very good at muscles, bones, joints, or at least I am or was. And we're not so good at a lot of those other niche aspects of healthcare, and especially challenging questions. It's a very emotive subject, miscarriages, and so it can be difficult to bring up. But we have to be sort of brave and be able to do that within the clinic, or we will miss these patients.
Exactly. And depression is one of the commonest symptoms in people with fibromyalgia, polymyalgia, rheumatica. But many of the physios never been trained what are the questions we should ask to screen for a depression. If the patient is clinically depressed, or depressed psychologically, all those things, they don't check. This is where most of the physios think that, yes, I'm happy with the rheumatoid arthritis, I'm happy with the gout, I'm happy with the psoriatic arthritis, but I don't know anything about soft tissue disorders, connective tissue disorder. That's where we tend to keep the patients longer and longer rather than needed. That's where the misdiagnosis happens. The next point I want to talk to you about, when we suspect some of this connective tissue disorder, is it just sending to the doctor or a local rheumatologist is the ideal area, of referral, or should we look for any tertiary hospital in London and send them out to, UCL or somewhere else?
Yes, again, really difficult logistical question. It probably depends a little bit on the patient, how easily they can travel. You should be okay with a I was going to say normal rheumatologist. That's not right, a general rheumatologist, and they will tend to see those patients initially, and then if they need help, seek further assistance. And it's very difficult for us to say, as non-rheumatological specialists, within a secondary care, to go, you're complicated enough to go to a specialist centre. That's probably not our job. So I think, generally speaking, it would be to the most local rheumatologist and let them make a decision whether it's within their skill set or not. And typically that's the route most people would take. They can seek private healthcare, of course, and then all roads are open, and then I would go looking for a specialist connective tissue disorder rheumatologist at that point. But most rheumatologists are very adept at picking up the more common types of connective tissue disorder, and then they know where to go if it's rarer or weirder or less specific. You can get some undifferentiated connective tissue disorders, for example, which are just almost impossible to diagnose without being in tertiary care. So they will know usually what to do. My worry with a lot of these kinds of patients is that people doing investigations, for example, too early in the journey, because so if you look at lupus, for example, then the main blood test you would do for that would be an ANA, an anti-nucleic acid.
Yes.
And that is fairly useful, but not definitive. So, and a lot of people don't necessarily understand how positive the test needs to be. And then you have the problem that I sort of talked about right at the beginning of these connective tissue disorders. If it might not be lupus, it might be Sjogren's or a slightly different connective tissue disorder where ANA is less useful and you need other antibodies. So you've got to be really confident you know what you're looking for, and then really confident you know what to do with that exact result, because an ANA positive result can be irrelevant in lupus if it's not high enough. And that's where we get a lot of problems, both with over-referral to rheumatology, because a positive ANA is extremely common in the population. About 20% of people have a positive ANA blood test without any symptoms and will never get lupus. And then under-referral because people haven't got the right bloods or done whatever. So it's really, you have, my opinion of the connective tissue disorders is really try to refer to rheumatology based on clinical suspicion rather than those bloods, because of the complexity. Once you drill down into those individual cases, it gets really difficult to understand exactly what bloods you need to do and what they become positive and negative. And then, like I sort of alluded to earlier, some of the more specialist ones for things like Sjogren's syndrome,
Yes.
They're not even available in primary care. So you can only get them in secondary care anyway. So you can't even test for them.
Are you referring to HLA-B27 or some other investigations?
So HLA-B27 for your spondyloarthritis, like ankylosing spondylitis, but anti-Rho, anti-LAR antibodies. There are a variety of versions of those. Don't ask me what those all stand for, but you can't always get those out at primary care because, again, they're expensive, but they're also difficult to interpret, so that oftentimes pathology departments won't, even if you're correctly asking for them, they'll say you're not the specialist, so
Exactly.
No, you're not having it. We're not spending all that money when we don't know definitively that you know
That is
that's
the
right
path the
thing.
patient needs to
Correct,
go.
yeah.
And what are the investigations would you recommend just for educating a physiotherapist on this podcast? If we suspect some soft tissue or connective tissue disorder here, would you recommend radiological investigation more often than bloods, or both equally? What is your understanding of this?
So probably the most useful one in the connective tissue disorders is actually an ultrasound of the wrist. So the most likely place to find synovitis in the connective tissue disorders is the wrist. So especially if you can do it either you can do it in your clinic or you've got a colleague that can do it there and then, you can go looking for that synovitis. Or if the patient's got finger pain, you can look for the fingers. So you're looking for those inflammatory changes. So I think an ultrasound is probably the most useful, because you don't have to wait if you've got the access to it. It's pretty cheap. And you can see a lot with that. So that's probably the most useful one, and also the most specific, because you can go, oh, I can see synovitis in that wrist. you then don't really care what it's causing it. You know, okay, I'll send that to rheumatology. I was suspicious, now I'm seeing that. You can go to rheumatology. Rheumatology can pull that apart, work out exactly what it is. Whereas with the bloods, you've got to be a lot more specific. Do you know what I mean? You can't, there's no point outside of ankylosing spondylitis, etc. There's no point doing a HLA-B27. It's irrelevant. So you don't have to be so specific with the ultrasound. So that would be what I would go for, really.
And do you think, as a physiotherapist, we over worry about these connective tissue disorders and investigate a lot more on the bloods? Or do you think our perception of, referring people to the specialist and leave it there? What do you see?
I see a combination of everything, really. You tend to see, patients that I see second opinion, you see either people have completely ignored them, they tend to be the people that end up with a diagnosis of fibromyalgia, or you see people where they've gone too narrow too early and they think, oh, I think that patient has systemic lupus erythematosus. I did this blood test. Actually, they didn't. They had Sjogren's syndrome, and they needed to do a different blood test, or they needed to do something else. And so they did the blood test. It was negative, and they didn't refer into rheumatology. So I see those two subsets of patients in this cohort. So my advice generally is, if you don't specifically know what you're looking for and you don't know what to do with that result, positive or negative, don't do it. Okay. Send to rheumatology, or at least ask a rheumatologist what you need to do. And then you'll be far better off and
safer, and you're not putting the patient at risk either.
Correct. And we just see this throughout. It's not just physiotherapists. My wife happened to go to a blood test recently for a completely unrelated problem, and they did a rheumatological screen. She has no symptoms of a rheumatological disorder at all. So obviously they came back negative. What a waste of blood testing. And I think it's about as much about waste as it is about false positives and seeing things that are irrelevant that have come back. And I often say to the people on my courses, it's like, if you're not in rheumatology and you're testing for a disease, you've got to be so confident that's the right disease, because if it's not, so psoriatic arthritis versus rheumatoid arthritis, really common one.
Yes.
All the bloods for rheumatoid arthritis are by definition negative in psoriatic arthritis. So if you're wrong, all of those bloods will back you up and you'll just send that patient off somewhere else. And as you say, push them down the road for longer and longer. So you've got to be so confident. How often are you that confident in your diagnosis before the bloods that you're not wasting them? And I think it's just really difficult to tread that line. So clinical suspicion is by far the highest. And then I really like an ultrasound, especially point of care. And then bloods if you're confident.
Yes.
And you can get more generic bloods, inflammatory markers, ESR, CRP, they can be of use. To see that there's definitely inflammation going on. That's probably there. And then the specific ones, you're getting into tricky territory.
Many of the time, doctors just order RA factor and say that, oh, you're not a rheumatological patient and it's negative. I say that can be negative, but there are tons of other problems, in the rheumatological world that needs to be excluded. Can you get you to refer to a rheumatologist? That's a safe place to be in. How do we tell the patient time and time again, RA factor is one of the investigation, that is not the golden,
Yeah, if anything, it's probably the least good test that we've talked about, rheumatoid factor. And I think, so what I tend to do, so I almost my entire caseload is second opinion. So they've already seen multiple clinicians or even a rheumatologist, and then they come to see me. And so what I tend to do is, if I'm suspicious it's a rheumatological disorder, then I will spell that out in my referral letter, and I will utilise what I know as the key markers of a rheumatological disease. So you mentioned early morning, being worse in the morning. So I make sure that's front and centre. The patient is worse first thing in the morning for an hour at least. They respond really well to anti-inflammatories. They wake up in the middle of the night with their symptoms. Their symptoms are worse with rest rather than activity. And then I don't tend to request things specifically. I'll say, I think this warrants further investigation under rheumatology. And there's two reasons I do that. One, I know if someone comes to me and goes, you need to do X with this patient, I'll do about 10 things else before I do that, because I'm like, I'm not going to do what you tell me. It's my personality. But also, it's a little bit self-protective. So I think, if I suggest that and they go, I'm not going to do that, I'm going to do something else, that eventually is not coming back to me as a problem. Do you know what I mean? Because you can't control other people and their clinical decision making, neither should you. But equally, you need to protect yourself a little bit. So I find the suggestive route goes much better. And, for me, it helps. It says rheumatology specialist under my name on the site when I sign the piece of paper. So I get a bit more gravitas with that. But it's about suggesting the route to do. And I think sometimes people can think you're a bit arrogant if you're saying, I read a letter the other day that someone had sent to the GP and it said, I think this patient has rheumatoid arthritis. I want this blood test, this blood test, this blood test, and for them to be referred to rheumatology. And it's just quite an aggressive way of doing things. And I think it's better to be a bit more open communication.
Open, because there are loads of other things at play and we are not 100% certain that is just this. Next question, I want to ask you about the treatment options.
Yep.
If it is a rheumatoid arthritis, the gold standard treatment is, DMARS or methotrexate, just the best and the gold standard treatment. Is there any treatment such as that for connective tissue disorders?
Yeah, no, is the answer.
That's a very quick answer.
So what tends to happen with the connective tissue disorders is it slightly depends on the disorder and the presenting issue and also the individual. So there are some drugs that you can give to some people you can't give to others. Hydroxychloroquine, for example, you can't give to anybody with an eye problem. So it is difficult. But typically, they would start someone, if they had sort of mild to moderate disease, then they'd look at something like sulfasalazine or hydroxychloroquine, or there are some others they can try to see if it can bring the symptoms down. And then if it's severe disease, it typically ends up being steroids, prednisolone, to try and get the symptoms down. There are some other medications that are a bit less used. They're a bit unusual in the other rheumatological disorders. Things like mycophenolate, I might be mispronouncing that, leflunomide. Yep. There are some other variations that they can try. And again, you're starting to get into prescribing, which is outside of my skill set, but they will trial some of those, again, depending on which types of symptoms people have. And so there is a variation, but then what you're lacking is their movement onto biologics. So that I mentioned the lady I spoke to, she's actually the first person in the UK to be having this new biologic drug, which they're using. She has Sjogren's syndrome. So they're only now trialing biologics. So if you think about how a drug is rolled out, that is still 5 to 10 years away from general release. Should that work? They're confident about it, as they always are in drug trials, but we're still a long way away from that, and that's because it's so vague, and we're not seeing a huge amount of inflammation that you can visually see, that you can score from a patient point of view. It's really difficult. I've got a toddler, we were talking about before this. How would I rate my fatigue today? I slept all right last night, but the night before, am I a 6 out of 10 or am I a 7 out of 10? It's really difficult to gauge those kinds of outcomes. So you've got all these problems with trying to manage, and then you don't want to give people drugs that are going to make them worse or problematic in another way when it's not going to work. Very difficult thing to manage.
Wow. And is there any medications or the doctors should prescribe for fibromyalgia syndrome? And I know polymyalgia rheumatica, people do go on steroids for a short period of time, then need to be tapered down. But again, that's not very well titrated by the medical world. I get angry about it sometimes. You are playing with steroids. But deal with it respectfully, and the patient is on the wrong end of the stick if they are on long-term steroids. What are the treatment options medically available for fibromyalgia syndrome?
So analgesia, from the humble paracetamol all the way up to some of the more complicated drugs that can also treat depression. They go through the variety with regards to that. I hope we're moving away from the opiate treatments. They tend to not be good for fibromyalgia, and in the long term actually make it a lot worse. So those are the main things that tend to be used to try and get on top of the pain aspect of it. But like I say, typically there'll be antidepressants common, because as you mentioned, depression is commonly interlinked with fibromyalgia, whether it's the cause or it's the effect it's difficult to understand. But those usually are the most common ones. And then typically you'll look for other things that might cause either increased sensitivity to pain or the pain itself. So they'll look at vitamin deficiencies, typically vitamin D, vitamin B12.
Yeah.
So you might, if you can consider those a medication, you might get supplementation for vitamin D, vitamin B12, etc. So having a look at those tends to be sort of the mainstay of treatment. Otherwise, we're really limited on the treatments we've got for something like fibromyalgia.
I do recommend acupuncture and various other treatment options to people. And something works for people and they want to stick to it. And I said to them, if it works for you all, just keep going. And mindfulness is another thing. People try that just to calm their mind down. So the depression part of this far, far less, and they are not irritated by that altogether. Where are we as a medical community at the moment in diagnosing when you compare UK against the world? Because a couple of my friends work in America, they say their diagnosing and screening of rheumatological conditions is far quicker and far more accurate than UK. What is your take on that?
Yeah, my understanding is we're pretty equivalent around the world. You get some slight improvements versus others, but not majorly. There was a big study on ankylosing spondylitis, for example, and the UK was equivalent to Canada and Australia and the US. They were all about the same. So I think if you take a snapshot, if we looked at patients in 2024, you might see a difference in different countries just per chance of statistics. But if you go over 10 years, you're probably looking about equivalently the same. And we see that historically as well. So I mentioned about 8 years delayed diagnosis for ankylosing spondylitis. That hasn't changed since 2000, the year 2000, and now that's still the same. It's not actually coming down. And there are various reasons for that. We're picking more of the patients up, for example. And the same with lupus, that's still quite well delayed. So I think it would be slightly arrogant for one country to say, we're better than other countries. And, the US has a slightly different, very different medical system. So that has pros and cons. Yeah, exactly. And also their reporting is very different because of that access. So I bet if you looked at the wealthy side of the US, you would see a very short duration. But we know in the poorer side of the US, which predominantly affects their African American population, that's not going to be anywhere near as good. So I think you can manipulate some of those numbers however you
want
like.
To
but
talk.
We have very big. It's got nothing to do with me. Very big registries now run by a lot of the drug companies where they follow patients for a long period of time, 25, 30, 35 years on these different drugs. And we've got huge amounts of data and they've got huge amounts of data. And it seems pretty equivalent.
The one topic I did not talk more about is ankylosing spondylitis. That itself a huge disorder. And if a physiotherapist seeing a musculoskeletal patient with a back pain and the patient is quite young and they're not sure, is it sacroiliac pathology or is it ankylosing spondylitis starting stage? How would you ask them to take this situation?
So I always think you're building a clinical picture, and then with something like ankylosing spondylitis, at some point you make a decision.
Yes.
So we talked about 80% of the population I think are going to get back pain, and only maybe 0.5% are going to get ankylosing spondylitis. But at some point, those intersect with likelihood, right? So you've got a big difference in likelihood and then something. So you need to look for the things that make the ankylosing spondylitis more likely. So, like you said, young, male, typically, although a lot of female patients as well, probably nearly equal. But then it's the symptom presentation as well. So worse in the morning, the volunteering of the word, stiffness, waking in the second half of the night, really strong response to anti-inflammatories. So that would be your sort of typical inflammatory type back pain. Family history of HLA-B27 disorders like psoriasis, uveitis, inflammatory bowel disease, or those diseases in the person. So you build this picture. So I always think you stack it. So if I had a 25-year-old patient in my clinic who had back pain for 6 weeks, I wouldn't be suspicious of ankylosing spondylitis. If I had a patient in my clinic who was 25, had back pain for 6 weeks, and they had ulcerative colitis, now I'm suspicious. Would I refer that? Probably not. I'm looking for another thing, something else.
Okay.
So either peripheral tendon pain or an inflammatory nature to the back pain. So they're much better with anti-inflammatories, or they're far worse in the morning. Then I'll do the referral. Then you get into the duration. So 25-year-old patient, back pain, ulcerative colitis, 6 months, I'm suspicious again.
Okay.
Higher. So, but it's not one thing. So you stack it on top of each other, and at some point it intersects. Now in my clinic, they intersect quite low because
Yes.
I see a very rigid subset of patients, almost all of which have inflammatory disease.
Yes.
Whereas in a general musculoskeletal clinic, it's going to be much higher. So you need to know what you're looking for, and you need to have in your mind, where is the line that I draw here? And there are ways of doing that. So the Spade tool,
Okay.
spadetool.co.uk is it's a tick box form, but it gives you a likelihood of someone having developed axial spondyloarthritis, which is, ankylosing spondylitis is one subset. So it will tell you how likely that is based on the patient's symptoms. So that's a really useful thing to do. That can really help your clinical reasoning process. And I think a lot of people will find they put their patient, you go back over your last number of back pain patients, you'll find some of them satisfy the criteria. But again, it's like we talked about before. If people aren't asking about past medical history, they're not asking about ulcerative colitis, Crohn's disease,
Exactly.
uveitis, or the patient volunteers and they don't know that that's related.
Related, yes.
That's when you miss these patients quite readily because they attend with back pain or tendon pain. And that's what we see day in, day out in a musculoskeletal clinic.
When I worked in a hospital setting, and we used to have a conversation with the physios who specialize in rheumatology and the physio specializing in musculoskeletal world, we always think that if you need to be good at rheumatology, you need to be a nerd in bloods. Honestly, and we would say, he's a nerd, don't talk to him, he's mad because he's looking into the blood so well. Is it the same situation even now?
No, I don't think so. I mean, like I say, if I went to teach a course today and it was general musculoskeletal physios, so they sit in a clinic and they are referred patients. I don't teach them the bloods. I tell them what they're
Yes.
interested in, but I'm not really talking about interpretation. It's all about clinical presentation.
Exactly.
So it's like, what is this patient presenting with? What can you see? What can you feel? And what is that collection of symptoms that makes you suspicious? And to be honest, in that scenario, I don't care if they can distinguish between rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and lupus. All I want to know is that they can go, that looks like a rheumatological patient, go to rheumatology. Now, if you're in a different role, if you're in a first contact practitioner role, or if you're in secondary care, then you probably need to be more specific. It's your job to be more specific. Then you need to do some more interpretations, and you probably need to be a bit more of a nerd about bloods and imaging, etc. Know which are the right types of imaging to get the bloods, etc. But yeah, most of us don't need to know that. I can't access any of those things from my clinic, so theoretically, I wouldn't need to know about that. So I just get them to go to a rheumatologist. That's your sort of low bar. If you can get the right patients to rheumatology, that's the best outcome. More than that is then extra positive, really.
Perfect. It's a fantastic conversation, Jack. Thank you very much for
Pleasure.
coming. And it'll be mind-blowing for many of the physios who are listening or watching this on YouTube. And I will ask them to, go to your website and check you out properly so that they can learn further and more. But it's an amazing conversation. Thank you very much for joining me on this podcast.
Delighted. Thank you. Thank you.
Thank you, Jack. Cheers.